Second, ma'am.
Can we
Yes, ma'am.
start, Arun?
Yes, ma'am.
Yeah. Good evening, everybody. This is indeed a great honor to have so many seniors in our presence, and we are going to start a new webinar series, and it again under the able leadership of Durgadas sir. So this is the KSOGA Gyanadeepa webinar series, and this we are hoping to come with every week with some new topics and interesting panel discussions. And this is the first episode, and we are hoping to cover all the Foxy societies. And this time, this webinar series, we are doing it with about 9 Gujarat societies. And it's a great pleasure to have so many seniors amongst us. So with this, I would welcome you all. We will have the invocation, and then I would request our KSOGA Secretary, Shobha Gudi ma'am, to give a welcome address. Invocation, Arun.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. I request KSOGA Secretary, Vice President Foxy Shobha ma'am to address the gathering. Thank you, ma'am.
Yeah, thank you, Srimati. And it is Vice President-elect this year. The Vice President from South
definitely.
yeah, is Dr. Vidya Tobi. I am the Vice President-elect. So thank you for being, again instrumental in being the compere for yet another what promises to be successful series of webinar, Srimati. And I think now Dr. Durgadas has established himself as quite the organizer for academic events. And we are very happy and proud that today we have so many academicians from Foxy as well. So my salutations to our chief patron, Dr. Hiremat sir. And thank you, Dr. Durgadas, for having me here. And my respect to the Foxy President 2020, the pandemic President, Dr. Alpesh Gandhi. I had the good fortune to serve as chairperson along with him, and so very proud of my association with Alpesh. And of course, all the brilliant speakers. I was listening to all the accolades for Dr. Bellad and Dr. Girardi, and I couldn't agree more that we have a fantastic array of speakers. So without further wasting of time, and I'm very happy that you have brought in such relevant topics today to the forefront, and you are having wonderful speakers, even out of state speakers. Welcome to Sarfraz Kazi also. And of course,
hello, ma'am.
We can see Sheila, the ICOG chair, gracing the occasion. It's wonderful to see Kunju Mohiddin as well. So welcome everyone. And over to Dr. Durgadas. And I must say, KSOGA is very proud today that we have yet another aspirant for chairperson, Dr. Durgadas Asrana, for the Committee for Safe Motherhood, and wishing him all the best. I hand over the mic to him for further. Thank you. Thank you, everyone, and welcome once again.
We request our President Durgadas sir to take over and introduce the chief guest. Thank you, sir.
Good evening, everybody. Respected Chief Guests, Dr. Alpesh Gandhi sir, Dr. M.G. Hiremat sir, Dr. Sheila Mane, Dr. Kunji Mohiddin, and all the invited faculties. I am very happy that with a very short notice, with the help of Dr. Kazi, we could get in touch with you all. Today is the birth of KSOGA Gyanadeepa webinar series. The first webinar is going to start today. The first light, the Jnana, the Deepa of this Jnana is going to be lit by all of you today. The concept is to link the Karnataka state with other state societies so that together we can work for better learning and better management of our patients. Along with Dr. Alpesh Gandhi sir, I also invite today's speaker, um, Dr. Raju Gireddy, whose session is going to be chaired by Dr. Sanjay Brahmabhat, who is the president of Anand Society, Dr. Hitesh Chavan, who is the secretary of Bhavanagar Society. The second speaker, my own good friend, Dr. Sarfraz Kazi, whose session is going to be chaired by Dr. Nikit Patel, is the secretary of Anand Society, Divyesh Patel, secretary of Godra Society, Dr. Piyush Kumar, president of Junagadh Society. The wonderful panel going to be headed by Dr. M.B. Bellat, with Dr. Chintan Thakkar, the president of SOGOG, and Usha Gupta, secretary of Gandhinagar Society, both being the experts today. The panelists, Dr. Hiral Pandya, president of Bharuch, Dr. Falguni Thakkar, past president of SOGOG, Dr. Snehal, the president of Bhavnagar Society, Dr. Devraj, secretary of Junagadh Society, Dr. Devendra Parmar, president of Butch Society. KSOGA invites you all for today's platform. For those who don't know, Raju Gireddy is one of the wonderful speaker. He is an excellent sonographer. To the core, the speaker to the max of great caliber. Sarfraz Kazi, I don't no need to tell anything. Your own boy. Coming to Bellar, my good friend, he has done lots of work on anemia and pregnancy. That's the reason we have chosen this topic. He has won the Best Teachers Award twice. He has been awarded FRCOG very recently. I request each and every Gujarat society to log into this, at least the recorded version, not to miss these three topics. With these few words, I welcome Dr. Alpesh Gandhi sir to address the gathering. Can I have the CV of Dr. Alpesh Gandhi sir?
Arun, CV, please.
Dr. Alpesh Gandhi sir is the past president of Foxy, is the Foxy representative of AFOAG, is the Foxy elected. Sorry, sir. Recently, he has been. Um, he's the from Foxy. He got elected for Suffolk. He is the national convener of Foxy's AAA HRP Care Accreditation Initiative. He is the president of Justice India Association. RCOG has awarded honorary FRCOG. IFCPC awarded him with 7 Legends of the World in 2021 for cervical cancer prevention. He has been awarded with Abdul Kalam Living Legend. He's been awarded totally 61 orations. Not this is old one. 61 orations to his credit. He has edited and contributed many textbooks and national guidelines. His chapter is in the textbook of FIGO. He has been awarded with Best Paper, Best Publication, and Best RCH Activities, Best Society, and many others. He has organized one of the most successful ASOG in 2019. He has much more. This is a gist of the things. We can go in pages together. With these few words, KSOGA welcomes you, sir. We want to hear your blessing words. Thank you, sir.
Dear Chief Patron, Dr. M.G. Hiremat, Dr. Nagaraj, today's chief guest, Dr. Hiremat, Dr. Sheila Mane, Dr. Kunji Mohiddin, and President Dr. Durgadas, Secretary Dr. Sobha Gudi, all esteemed faculties and dear friends, a very good evening to all of you. At the beginning, I would like to thank Dr. Durgadas for inviting me and for this honor to inaugurate this very important knowledge sharing KSOGA Gyanadeepa webinar series. Namaskaram to all of you. And uh, I'm I would also like to congratulate President Secretaries of Societies of Gujarat to join this webinar. I'm so excited to know the topics you have selected for this webinar. And I also came to know this is the beginning, this is the birth of this web series. So at the beginning of this web series, my best wishes to Dr. Durgadas and all of you. I'm so proud of you, all of you, for your academic and social activities. I know all of you personally since long, and I'm happy that you all are doing such a good academic activities. For this today's webinar, you have selected two very important topics: placenta accreta syndrome. The incidence of placenta accreta was 1 in 30,000 in 1960s, which has increased to 1 in 500. And that is why it is very important for all of us to know placenta accreta syndrome thoroughly and to update our skill and knowledge. It is said that the incidence of placenta accreta syndrome is more in developed countries than India, but even though the rate of case fatality rate is 10 times higher in India than Western world. This is because many time, even today, it is diagnosed accidentally during the cesarean section. We miss the opportunity to diagnose it during the antenatal period. Diagnosis is not so difficult with the gadget of sonography and color Doppler, but in spite of it, it is many times an accidental finding during the cesarean section. Second reason is still since so many years, we can say since last 1 decade, we are trying to update our skill, but still we need to do a lot to update our skill and our centers to tackle such situations. And third important thing is still it is many times operated at a place which is not a tertiary care center or not updated with the facilities. I will not go in detail of the technical aspects, how to diagnose, how to manage, because for that we have very two eminent faculty, Raju Giridi and Sarfraz, my friend Sarfraz Kazi from Gujarat. So they will throw light on it and we'll have a discussion and question answer session also. But thing is that it is increasing. Case fatality rate is very high in India. And if we want to reduce the maternal mortality rate, we need to update our skill and our centers to tackle each and every case of placenta accreta syndrome. Another important topic you have selected is anemia. Anemia, we can say it adds fuel to all the complications, morbidity, mortalities, everything of pregnancy. It is rampant. It is very high incidence in India. Since independence, we are trying to reduce the incidence of anemia in our country. But even though it is between 50 to 60% in different states, very high, it is 62% at many places. Incidence of anemia is very high, and incidence of anemia is not only a problem of a lower socio-economical class, but even it is found in medical students, doctors, and even in rich families also. So it is very important. Still, at many places, we can say even it's one of the study. It was found that even our members are not so much aware, or they are not so much interested in what is serum ferritin and so many other things. Dr. Bellard, who is, we can say, the authority on anemia in our country, is going to cover anemia in pregnancy. I'm sure our delegates are going to be benefited a lot from this two very, very important topic and from these eminent faculties. And I would also like to congratulate my friend Dr. Billard for receiving FRCOG. Welcome to the club of FRCOG, Dr. Billard. With this, once again, my best wishes for this web series and my best wishes personally to Dr. Durgadas for his future endeavor in mainstream of Foxy. I wish him best of luck. Once again, thank you very much for inviting me. Thank you.
Thank you, sir. Your wishes means a lot to us. We treasure it very much. Thanks for joining in spite of your busy schedule. Thank you very much, sir.
Thank you.
Now I invite our chief patron, Dr. M.G. Hiramat, to say a few words about this KSOGA Gyanadeepa web series. I don't want to read the whole biodata. In 2 3 sentences, what I can say is he is the torchbearer of our KSOGA. He was the founder secretary. Even today, I think nothing, no decisions are taken without his discussions. Whatever the great decisions are taken, it is going to be discussed with the MG Hiramat sir, and it's moved further. He is presently, because of his hard work, even in the academics, he has been given the Professor Emeritus Award in the KLE Hospital and the Medical College. The personal note, he was my thesis guide during my MD days. With these brief things, I think, sir, we want your blessings for this webinar series. Please address us.
Dr.
Thank
Durga
you,
Das, you
Dr.
are
Yes,
Durgadas.
fortunate
sir.
to have Dr. Hiremat as a patron for
Yes, sir.
always with all of you.
Yes, sir. Yes, sir.
Thank you,
The-
Alpesh. Thank you, Durgadas, for inviting me to this wonderful scientific program named as KSOGA Gyanadeepa. Truly, it will be Gyanadeepa for the whole year. I know the way you are putting efforts in bringing all the learned people in one forum. This only shows that Chief Guest Dr. Alpesh and Dr. Sheila Mane, Dr. Kunji Mainuddin, so many have joined. And along with that, galaxy of speakers, one full page of speakers are there. And I think it will be a feast to everyone that this session, which is going to happen today. And this is the starting of the webinar. I wish all the best for this webinar, and it will really make a lot of awareness about the topics which have been selected. Three topics have been selected for today's webinar: placenta accreta spectrum, techniques for conservation of uterus, and anemia and pregnancy. All the three are very dynamic topics, and they need to be learned because today they have become the major issues to be discussed. Particularly, as rightly told by my friend Alpesh, that placenta accreta spectrum. Earlier, we used to see placenta accreta only when we are doing cesarean and end up with the problem. Today, ultrasound has made a lot of difference so that in your routine antenatal period only, you can look it for and you can identify and you can take all the precautions. And the conservation of the uterus is again, we are telling that uterus has to be conserved. And now this is one of the ways which is to be. And Dr. M.B. Bellad, my good friend who got FRCOG very recently, will definitely dissect this topic of anemia to a great extent. I don't want to come in between any of the speakers and the learning process. I wish Dr. Durgadas to enter the Foxy as a chairperson, that with a very highly rated the Committee of Safe Motherhood, which can cover every aspect of women's health. And I think Durgadas, I wish you, and I wish all the presidents and secretaries of 9 societies who have taken very active part, and everyone has joined here. It will be really a feast that to learn. And with these few words, I wish once again this program a grand success and let it run for a very, very long time. And KSOGA will flag very high with this program also, because every time my colleagues, when they are entering we had KSOGA Gnana Harsha. Then we had KSOGA Vision. So many things. And now Durgadas has come as Gyanadeepa. I wish you, Durga, all the best. Thank you.
Thank you, sir. Thank you for your wishes. Thanks for even though I can make out you are logging in from your office, even in the busy schedule, you have joined us. Thank you very much. Thanks for your blessings. Now I request our good friend Dr. Sheila Mane. Sheila Mane doesn't require any this thing. Sheila Mane, she only one sentence I can tell is she is the president of chairperson of ICOG, a good friend of mine, popularly
Yeah,
known
Thakur.
as
Enough. Yeah. Arun, you can stop sharing.
Popularly known as PPH lady. She has been recognized by Karnataka State Health Department to have the mortality analysis of the whole state. You can make out the caliber of her dedication to the society. With these few words, madam, please address and be a part of this inaugural webinar series. Thank you.
Thank you. Yeah, good afternoon, Dr. Alpesh Gandhi, Dr. Hiremat, Dr. Kunja Mohiddin, and Dr. Durga Das, Dr. Shobha Gudi, Dr. Srimati, and everyone here. Okay. And Dr. Kazi, who has taken the initiative with Dr. Durga Das. I think regarding the topic, everybody has told us the importance of the two important topics today. And all of us, we know that if we deal with this, definitely we can definitely improve the outcomes of the complex pregnancies. And I really like the idea of Dr. Durgadas of selecting these topics because he is aiming for Safe Motherhood Committee chairperson. And these are the things, which you start thinking before you become, because you know the importance that itself shows that the person has so much of interest to work for this committee. That is important. So you are already making a base that what all is required now when you become a chairperson, and the word is already spread regarding this. That I really like it, and I really congratulate you and my best wishes to you. And one more thing I would like to be doing associated with KSOGA is as a ICOG chair, I'm planning to do the registry for PASS all over the country, at least in major cities. Okay. So through KSOGA, we will try to do it for Karnataka, the PASS, placenta accreta syndrome, with every society, and we will have a big data collection for that. And then we will be able to find out that what is that which is causing this, in which cases we find it more. So, I mean, we do some research, and through this I think it will lead us, so that that will give us some clue for the prevention. What are the preventive strategies and how we can reduce it? So that is what I look at it. And, yeah, so that is what I wanted to tell as the ICOG chair. And once again, I congratulate everybody and my best wishes. And I know that all the speakers will definitely do a good job. And this webinar and web series has become a very good way of reaching people and spreading knowledge. And those who are and focused will definitely join. And I can see that so many societies have come together, and definitely it will benefit. So once again, I congratulate one and all and my best wishes for this webinar. Thank you.
Thank
So
you.
Shubha,
Thank
it's a
you, Dr.
good
Sheila
idea
Mane.
to begin with the pass at the ICOG level.
Okay, thank you, sir. Thank you. Thank you, Dr. Sheila Mane. Now I request my friend Dr. Kunja Mohiddin to address our our webinar. Dr. Kunja Mohiddin is CV.
Next.
Kunja Mohiddin is a great infertility specialist in south of Kerala with 27 years of experience, and he is a candidate for infertility committee of Foxy. With these few words, I request Dr. Kunja Mohiddin to say a few words regarding our webinar.
Yeah. Good evening, all. Respected chief guest, Dr. Alpesh Gandhi. I'm so happy to share the platform with Sir because during his year, we got our society materialized and we got Best Society Award in Oncology during that term in spite of COVID times. And Hiremat Sir, Shiramane Madam, and the President of KSOGA, Dr. Durga Das, Dr. Shabagudi, and all the participating presidents, secretaries, the faculty, Balad Sir, Sarfraz, Raju, and this webinar, it is going to be a great success because of the relevance and the importance of the topics selected. So let this be a good opening eye and knowledge sharing platform for all the participating societies, presidents, secretaries, and their members so that they can be enriched with all the experiences of the faculties who are going to share in the coming next 2 hours. So with this few words, I wish all the best for this webinar, and I also wish all the best and success for all the future endeavors for Durgadas for competing for the Safe Motherhood Committee. Thank you all.
Thank you, Kunju Moideen. As I have told, he's also trying to for chairperson post of Infertility Committee. Thank you. With these few words, I hand over the platform to yes, I hand over the platform to Dr. Srimati and Dr. Suvarna Gulet for the scientific activity. Please carry on.
Thank you. Thank you, sir. So, with the blessings of all the seniors and, of course, with our wishes as well for both you as well as Kunjumuddin, sir, we will start this webinar. So, can we have the CVs, Arun? So, we are going to have two talks. The first talk by Dr. Raju Giradi, who's going to be speaking on ultrasound assessment of placenta accreta spectrum. For that, I would like to invite our two esteemed chairpersons, Dr. Sanjay Brahmbhatt, sir, and Dr. Hitesh Chauhan, sir. Dr. Sanjay Brahmbhatt, sir, he's just finished the surgery and he's just joined us. Thank you very much, sir. He's a president of the Anand Society in Gujarat. Sir has done his MBBS and MD from BJ Medical College, Ahmedabad, Gujarat. And he's the ex-assistant professor at Sri Krishna Medical College and Hospital, Anand. And is currently working as a laparoscopic gynae surgeon and as a gynae oncologist at Himalaya Hospital. And he's also visiting laparoscopic surgeon at Vagodhya, Vadodara. And he has performed more than 1,000 laparoscopic and hysteroscopic surgeries. And he has also been a great trainer and he has trained nearly 150 gynecologists. It's indeed a great pleasure to have you with us, sir. And we also would like to invite Dr. Hitesh Chauhan, sir, who's the secretary of the Bhavnagar Society. Thank you very much for joining us, sir. Sir is a DGO from the College of Physicians and Surgeons, and he's experienced obstetrician and gynecologist, and a special interest is in high-risk pregnancy and also in gynecological surgeries. And he is currently affiliated to Ma Maternity Hospital at Shastri Nagar, Bhavnagar, and has got a work experience of more than 10 years and is also a life member of IMA. It's indeed a great privilege to have you with us in this webinar, and I request you to introduce Dr. Raju Giradi, who is a speaker. Thank you, sir.
Thank you, ma'am. Thank you for a wonderful talk. Good evening to all respected seniors and my colleagues. At the out of box, congratulate to Dr. Durga sir and for arrangement of the wonderful webinar. SOGA Society has a wonderful arranged webinar, first episode. And thanks to also for giving me opportunity to participate as the chairperson in this wonderful webinar. At the out of box, without wasting a time, I most welcome to Dr. Raju Girdi sir. He is a MS obstetrician and junior consultant at Bedapur Hospital, Raipur, Karnataka. He is a fellow in fetal medicine. His special interest of area is pelvic imaging, fetal medicine, and high-risk pregnancy. Sir has been giving a topic ultrasound assessment of the placenta accreta spectrum. So stage is yours, sir. Kindly addressing the wonderful session. Thank you so much, sir.
Raju, before Raju starts, I want to acknowledge the presence of my guru, Dr. H. Nagaraj sir, who has logged in. Thank you, sir, for logging in. And will you please wish us for today's Nagaraj sir? No, he has muted. Okay, Raju, carry on.
Namaste, good evening, everyone. At the very onset, I feel really honored and delighted to be present here in this wonderful event of having the sessions of learning platform of KSOGA. It's really a honor, sir. I seek blessings from all my beloved teachers, especially the patrons of KSOGA, sir, MG Remet, sir, and my beloved sir, that is Durgadas, sir, and all the secretaries. It's really an honor to be present with the platform of having Bellad sir, my teacher, who has guided me and molded me what I'm. So without wasting time, I thank Hitesh sir for giving introduction. Thank you so much, sir. So today, as sir has taken this topic of the placenta as well as the anemia, which are the two most important topics that we need to address with respect to the motherhood for the having a safe delivery or having a safe pregnancy. So me being an obstetrician, I will be covering the aspect of USG assessment of placenta accreta. So why? Well, because we all know that this is going to be for most of us a nightmare. And why is it so? One second. One second, sir. Sorry. How to get back to the main screen?
Sorry, what happened?
How's it, sir?
I'm seeing the whole screen of the speakers, ma'am. I'm not able to see my screen of the.
No, you go and switch to that one. Active view. I think you probably put the gallery view. If you
Yes,
go to
ma'am.
the top, there will be a switch
You?
to speaker view.
Yeah.
You've got that. At the top, you're seeing the speakers. No, on the left-hand side, there will be a button which speaks about switch to view.
It is speaker view. It is there. I have to switch to gallery view, ma'am.
No,
No,
no.
no, no. You should be in the speaker view because if you're in the speaker view, you'll be able to see yourself. Gallery view will bring in all the speakers.
If not, stop sharing, sir. Share it
And
again.
then restart, sir.
Yeah,
If you
sorry,
stop
sir.
and restart, you'll get it. Now, if you restart, you'll be able to get it.
Is it seen, ma'am?
It is, yeah.
Yes.
Yes.
Yeah, yeah. You are able to
It's
put a
like
slideshow, sir?
Yeah.
Yeah, perfect.
Ma'am, my whole screen is seen, ma'am.
yes, yes.
Yeah, yeah,
Thank
perfect,
you,
sir.
thank you,
It's
thank you so
perfect.
much.
Thank
So,
you.
because why we call it as an obstetrician nightmare is because we all know that we don't want to have surprises like this on table. Some of you would have really experienced this. That is the reason why we'll take up about USG. Why USG? USG is the most simplest and the most feasible mode of imaging these days because every obstetrician is known to be well known for this instrument, and also you have every obstetrician in his clinic or unit that he is been able to do USG himself. So today I will be going into the brief introduction of this topic, and then we'll see because we all know in fetal medicine, most of us look into the fetus and the liquor and the Dopplers, but we really miss out giving importance to the placenta. We'll try to see that what in placenta we need to look, and we shall get into the topic proper, that is knowing the morbidly other in placenta. Also, we should try to know what are the false positives and pitfalls in USG while we are assessing it. Most important, I want to take up today is how to get to know that in the first trimester itself, can I have uh, a red flag sign in the first trimester that this is likely that I'm going to deal with the placenta accreta in the future. So that is the most important take today, where I will be discussing on how early we can diagnose this entity so that we're going to avoid on-table surprises. So I don't want to get into the incidences because sir already told it is now it is almost getting down to 500, 1 in 500. Yes, sir, it is definitely. So we know it is because of the defect in the decidua basalis. Maternal mortality may range up to 5 to 10%. What is more important is after that, because now surgeons are getting skilled and the referrals are being far good enough these days, where the patient is referred to the higher center. The morbidity and mortality is definitely coming down within expert hands. But still, to come for the completion sake, we will have to just cover because we all know how the spectrum goes. When the placenta gets adhered at the level of the myometrium, it is accreta. If it gets infiltrating into the myometral plane, it's going to be increta. If it crosses the serosa, it is type 3 or percreta. We have more classifications at A, B, C. If it is the serosa, then it is into the bladder, and then into the other organs as well, that it's going to be A, B, C. So in placenta accreta spectrum, we all know what we can call it as an adhered placenta or an invasive placenta, which can be furthermore divided into increta and percreta. So where does the problem lie? This is just for the completion's sake. The problem lies actually in the scar or the myometrium. It's not at the trophoblastic tissue. But definitely when you have a poor desodilization, and especially at the basalis layer, it tries to go deeper into the myometral planes and get into the vasculature, so that it has to get in the blood supply for the embryo that has got implanted. So if you have these lacunae, if you have this defect in the myometrium plane, this is a there is because, and we don't get into the spiral or the radial spiral arteries. So definitely it will go find deeper and deeper to find the larger high resistant vessels, that is the radial and the arcuate vessels. So risk factors, we all know. Obviously, this is the most common entity and the most common surgery performed worldwide, and definitely it has a lot of pros, but definitely it comes with a con that you can end up having this entity. So this is the most important entity, that is previous C-section. Rarely these things are to be covered for completion's sake, but definitely we have to think more in terms of what is the first two, that is the previous C-section and the anterior placenta previa. The curettage, obviously now we are going for a safer modalities of MVAs and all, and hysteroscopic removal and manual removal of placenta, which can cause definitely to sometimes the problem to the basal layer of the endometrium, if at all it is there, and postmortem endometritis. I had given the same talk in Bangalore when Sushila madam and Sheila madam had given me this opportunity, and it was Alpesh sir who was there in the class, and he also told Raju, it's not only always previous section which you put forth, it's also the IVF these days. So I want to add that IVF also in the recent scenario can get into placenta accreta spectrum. Rare though, but what is more important is we'll try to see how in USG we are going to look out for those. Ultrasound definitely a very good imaging tool now, because the the sensitivity is more than 80% now, but the specificity is almost very higher. It has gone more than 80%. Definitely with the good knowledge as well as the good machines, and majority of them are taking up TVS now. Definitely we are diagnosing this entity. The percentage is 80, but definitely it is more than that. But still, there are incidents. We know that the detection rate overall, if you look into the entire world, looking at all the population, the detection rate is less. It is still less than 50%. Why is it so? Because maybe there was no proper antenatal screening, or maybe the person who was screened has not looked the placenta properly, and that is how we get surprises at the third trimester and also sometimes at the on table. So typically we get these signs, especially in the late trimester or late second half of the pregnancy. That is when we do usually our growth scans or early growth scans. Then here, that is the role of the obstetrician here, that he plays a very important role. That just though I have written it as in later gestation, now we have to change ourselves, that how early can we diagnose this. So we'll just look into how a normal placenta looks. I thank my friend Manjunath Ukkeri, who is my mentor and my senior, who has been helping me out in my scans. So normally when you do in a B mode scale, this is how a placenta looks. It is uniform and it is echogenic. It is homogeneous and echogenic. Sometimes in later later gestations in the mid trimesters, you get the small anechoic spaces within the placenta, diffuse enough, not vascular, and these are usually the lakes. If you look into the placenta now, if you see this is the bladder and this is the bladder serosa, you have the serosal interface with the myometrium. This is the myometrium and this is the placenta. So 4 layers you should check always. One is the placenta, which is more echogenic. Then you have something, what is a small area, gray area, that is the hypoechoic zone. So these are the 4 layers that you should be able to define when you look at the placenta, that is the hypoechoic or the clear zone. Then you have, that was the more hypoechoic area. Then you have the more normal, that is isoechoic we call, because in scans we always compare with the myometral echoes to the rest of the echoes in the pelvis, and that in the last we have the bladder wall. So this is when you have a very good acoustic shadow, acoustic input from, because of the bladder is really helping us. So again, I want to repeat it. These four things that we need to able to see, that is the placenta, the clear hypoechoic zone, the myometrium. So this is the clear zone. So this is the take from my scan machine. Here you are able to appreciate a hypoechoic zone in between the myometrium and the placenta. That itself is a clear zone. So now sometimes you have a placenta which is posterior. We don't find the help of the bladder or the the interface because of the water there. That time you might find some difficulty in addressing the hypoechoic zone as well as the myometral echoes in the posterior placenta. But definitely with good resolution and decreasing the depth and taking box zooms, definitely you will be able to make these days in a bigger scan machines. Yes, sometimes when you are in doubtful, this is the area where you may have to depend on MRI for our, when you have a doubtful, but still in this case you are able to appreciate a clear zone, that is the hypoechoic zone. So in placenta accreta spectrum, when it is adhered, we all know, I was discussing that whether it could be an invasive part, increta or percreta. But let me tell you, ultrasound cannot reliably differentiate between these three types sometimes. Why? Because you may not be in the proper exact plane. In some planes, there may be inclusions of, that is why it is called that all three can coexist. You have an increta on some part, you might have percreta on some part, some part you might have a just adhered placenta. So spanning across the entire placenta, especially at the, if it is low lying and at the level of base of the bladder, you need to go across and find out where exactly you might find the pathology. So obviously we'll be discussing on B mode, because the most common mode that we all do are the abdominal scan as well as the TVS. The most important one that we should look for, if at all you are looking of suspecting a placenta and you are want to hit the diagnosis, look for this abnormal lacunae, which I will be showing in a few seconds, and the loss of clear zone. These two are very important in your B mode. If these two you are able to appreciate, then definitely you are likely to going to deal with the case of placenta accreta or a abnormally invasive placenta. So myometral thinning, and you have sometimes more prominent ones, like, if it is getting for percreta and having the placental bulge. And last, you can get this bladder wall interruption if the serosa is not looking clear and clear hyperechoic, and if there are interruptions because of the vascularity, then definitely it is a case of placenta accreta spectrum that you are looking into. So always add color whenever you do any scans, provided if it is first trimester and if you're looking at the Alara principle. But definitely when you look at the placenta, and if you're not getting, you're having looking at the interface between the placenta and the bladder, always put color. Always put color. That will add to your diagnosis, because you might find these utrovesical and subplacental hypovascularities and the bridging vessels, which are more specific to look into your color signs, which are going to give you the diagnosis of placenta accreta spectrum. Obviously, when you have these and lacunae, which I have told you in 2D that you are able to see, and if that lacunae are having feeder vessels, and if the whole lacunae is having prominent vessels which are filling within, then definitely it is a case that you're dealing with a serious problem of placenta accreta. Some few slides to discuss where, you are able to appreciate in the transvaginal sonography. That plays a very important role whenever you have an doubtful that in TAS we may not be able to look for the interface between the bladder and the placenta. Look here, you are able to appreciate in some areas you don't find this hypoechoic zone. So at some areas it is gone. This myometral echoes are not seen at some areas, and as I move across, as we move across the other planes of the placenta, you are able to appreciate these anechoic spaces which appear like moth-eaten, and these are hypervascular. So these are the lacunae that I'm trying to speak out. So to show you that, some areas you may not get that hypoechoic zone properly, which is very badly adhered. And once you look at the echogenicity of the bladder's interface, see, look here, this placenta is showing irregularities at the bladder base, as well as large lacunae within at the area near to where the placenta has got adhered. So usually the lacunae or these moth-eaten appearing echogenicities or the cystic lesions, what you see, are very closer and usually at the level where the placenta has got adhered. So, for example, in this case, you will be able to appreciate here a low-lying placenta or a placenta previa, but you find a good echogenicity of the regular line of the serosa and minimal vascularity. This is likely to be only a placenta previa with minimal adhesion. But if you have significant vascularity and loss of interface between this echogenic line of the bladder and loss of hypoechoic zone, this is where you need to look into that. Am I going to that this is likely to be a deep infiltrating invasion of this trophoblastic tissue? So that is placenta accreta spectrum. Very obvious here. You are able to appreciate the echogenic line of the serosal base of the bladder. It is having hypoechoic lesions, and when you put color, it is actually taking the color. So this is to show that these are all the bridging of the radial vessels that it's got getting penetrated into the bladder serosa. So this is what we got these days in a lot of papers we come across. Look here in 2D, when you find the interruption of the echogenic line of the bladder, and when you put color, it's going to show you. Usually it will be in alternate colors because these are perforating vessels which are in radial fashion. That is why you find these in intermittent alternating colors. So on intraoperative, you might find this kind of the invasions as you see at the bladder base. So what is that you need to look? For example, look here in this case where the placenta is densely adhered at the lower corpus and attached to the base of the bladder, you find lot many anechoic moth-eaten spaces, which if you closely observe in 2D itself, there are some features showing this whirling appearance of the echogenicities inside. That is to show that is a lacunae, which is having very, very significant feeder vessels. Yet another sign to show that it is appearing like a railroad or a rail track sign, where you have alternating the red and the blue, vascular zones that you see in Doppler. So this is to show that yes, this is one of the entities that we are more getting into specificity, that this is a case which is invaded into the bladder. So when you try to get a bulge, or when the lower corpus is got bulged into the bladder base and you find this moth-eaten appearance, these are the things that we should look for, and always play with your colors too, so that will add to your diagnosis more. Why am I trying to play again and again the same videos? Is that so that we will get into what exactly I am trying to show you, because diagnosis, it's usually simple and easy if at all you try to look into what exactly I need to look at. For example, the corresponding picture of showing how the bulge has got into the bladder, this is how it looks in the intraoperative picture. So this is one of the important signs. Sometimes you get into the pitfalls. What do you have? Look here in this sign, what you're trying to see. Undue pressure of the probe sometimes will feel that you are actually looking at the placenta accreta spectrum. See what has happened here. See, undue pressure is actually not giving us the myometral zones here. So if you release the pressure, you are able to appreciate that there is the normal myometral echo and the normal hypoechoic zone. So these are some pitfalls we are trying to see. But if at all it was a case of placenta accreta or a placenta increta spectrum, there will not be any fall. So there won't be any negative separations here. You are able to appreciate that you are not able to find the normal myometral planes. So this is one of the signs that we can really look for. The separation signs using your probe pressure. Those things are actually to be called as a pitfalls that we can have in our imaging. So in both the cases, you are able to appreciate when you put undue pressure here. If you put undue pressure, you will be losing some information. So definitely looking at the placenta, we need to be careful such that we are not going to miss the normal appearing myometral and the hypoechoic zone. Here also there was increased pressure, so we were not able to see this myometral echoes over here. See, when you reduce the pressure, you are able to appreciate the normal appearing myometral pressures. So we were worried of these echoes, right? These echoes, I told you in the first slide, sometimes when they are these anechoic spaces which are diffuse and they are not hypervascular, sometimes they might have a echogenic hue around and poor vascularity around. These are usually the lakes of the placenta, which are normal usually in the in the mid trimester and the late mid trimester. So what is the difference between a lacunae and a lake? So if you look here, you are able to appreciate at the level, this is the bladder, and the bladder interface has got interrupted, and these lacunae are not uniform. These cystic lesions are not uniform, and they're usually appearing moth-eaten, and on color they are appearing so vascular. So and one more important thing is that we should look for what is called as the positive pressure sign. When you put pressure with the probe, these lacunae are not compressible. We can also call this compressible test, where you put your pressure, these lacunae are not getting reduced. So these are prominent anechoic spaces when with pressure or your probe pressure, if they're not getting reduced, and these are likely to be your lacunae, and they're more pathognomic for your placenta accreta spectrum. Whereas when you look into these cases where you have usually well-defined lesions and sometimes a bright halo around, and they are usually diffuse, not only at the level of the bladder or the bladder interface, and they might have vascularity within, but they are very low streaming vascular vessels. But when you put pressure, I just want to show this clip. So if you put pressure on this, they're usually compressible. These lakes, what do you call, I'm trying to describe the lake here, how to differentiate between a lake and a lacunae. They are usually compressible with probe pressures. So that is how we need to define how to differentiate between a lacunae and how to differentiate between a lacunae and the placental lakes. So for example, you are able to appreciate here when the operator is trying to put pressure, they are getting compressed. So these are usually, though you find the hypervascular turbid flow within, but when you put color, they usually don't take so much of high vascularity what the lacunae takes. So this is all about the lakes and placenta, the lacunae. Yes, now this is the most important thing that we are all knowing, because the incidence of cesarean section has definitely gone shooted up like anything, and definitely we are at our indeed we are at the responsibility for looking or the complications if at all they are going to happen. So cesarean scar pregnancies of late are getting increased. Why is because people are trying to understand more better, and also the diagnostic modality with respect to imaging has also increased, so that they're getting good enough that they're detecting it in the first trimester itself. So first trimester detection plays a very, very important role, and we always should anticipate whenever in a case of previous LSCS, call her so early. That is what the duty of a particular obstetrician is. Before he discharges the lady after doing a cesarean, he or she should warn her that she should be educated about that, saying that your next pregnancy, if you miss your periods early, come early, so that we'll detect it, whether she may end up having a cesarean scar pregnancy. So that is how, because we all know these days the placenta accreta and the cesarean scar pregnancy are trying to share the same histology, which was given by Timor, and majority of pathologists also have papers have come up that they're saying that they have the same histology. So with increase in incidence of one cesarean, you have almost 3%, or almost if you have 3 cesarean, it shoots up to almost 40% of the cesarean pregnancies that we can have. Definitely, when you have a defect like this of isthmosele, we should be very careful. We should be warned that in her pregnancy she might have a cesarean scar pregnancy. So I have a very, very good audio over here, so this might benefit all. Please listen to this. Oh, I'm very sorry. I'm very sorry. I'll come back.
Raju, you can proceed.
Yes, sir. Yes, sir. Sir, is my screen seen, sir?
Yes,
Yes, yes.
Yeah, this is a very important audio. I would like to play.
Yes,
Please
yes.
listen
Go
to the
ahead, go
audio.
ahead.
So then you get your blastocyst and it comes down and it goes whoop right into the cesarean scar. And that would be a cesarean scar pregnancy. That's a cesarean scar pregnancy. And that's a cesarean scar pregnancy. However, if you're a little bit higher, that's just low lying. And if you're a little bit lower, that's a cervical isthmus pregnancy. So cesarean scar pregnancies are right in the niche. Now, what's really important when you look at this is you have to look for where the decidua is, right? We talked about the decidua basalis when I gave my talk on first trimester dating. This is why it's so important to recognize it. So you have your little embryo that's implanted, but it's where the decidua is going into that's going to determine whether you have a true cesarean scar pregnancy or not.
So it's very, very important that if you do our initial scans and try to look at where the decidua has got attached, that is where we are going to diagnose the cesarean scar pregnancy as soon as possible. These two pictures are just to show the importance of knowing the pathophysiology. When our normal trophoblastic tissues in a normal myometrial space, normal myometrial zones, you find these basal and spiral arteries, which has low resistant arteries are giving blood supply. But if you have a very large defect, you don't find these basal and spiral arteries to be developing, or the cytotrophoblastic invasions has not occurred. So what does the decidua go and try to get its blood supply from deeper planes of especially the arcuate and radial arteries? This is the reason why when somebody tries to do a DNC in a case of previous early pregnancy, in a DNC in early pregnancy, in case of previous LSCS, they might would have ended up having saying that when I put my cannula, she started bleeding torrentially. That is the what could be the reason? The reason here they have actually hit these high resistant vessels, which usually don't easily compress. So that is one of the reasons to show the pathophysiology in a CSP, that you find such catastrophic events in case of CSP evacuation. So we all owe to this gentleman, that is Ilan Timur Stitch, who has worked a lot on this entity, and he has given the diagnostic criteria apart from the not only diagnostic criteria and also the treatment modalities. So what is that he has shown? The trophoblastic invasion at the very early pregnancy, if you find so much of vascularity, yes, it is that we are dealing with this a cesarean scar pregnancy, which is having a lot of trophoblastic activity, and definitely this can lead to a Acrita spectrum. So he calls cesarean scar pregnancy as a baby Acrita. So what are the sonographic criteria? Look here, you are able to appreciate a gestational sac which is located more anterior and in the lower corpus, whereas the fundus, that is the corpus, is empty and the cervix is empty, and the gestational sac has got embedded at more in the lower segment, is it has got embedded near the scar area. So what will happen? Usually it will be in a triangular shape in the early pregnancy, and it get oblongated. If at all, it is going to be into the endogenic variety or the type 1. So I'll not go into those classifications, but definitely. And if you have a very less myometrial thickness these days, which have been added in the diagnosing criteria, if it is less than 3 mm, then likely this is going to be a CSP. So again, another important points to add: the functional trophoblast, increased activity of the trophoblast, increased vascularity. And see here, this case, as early as 13 weeks of gestation, when I was trying to do a TVS, you are able to appreciate the appearance of the cystic spaces at the scar, at the cesarean scar area. You are able to appreciate the early appearance of these smaller lacunae. So these cases are very early enough to say that this is likely to end up having a case of placenta acrita. So what will happen?
Well, this is a slide that was shared with me by Dr. Timur again, and it shows you what I now think you would look at and you say, that gestational sac at 6 weeks is too low in the uterus. You can see the decidua implanted in the niche. This is definitely a niche pregnancy, right? But the patient says, it's taken me a long time to conceive this pregnancy. I don't want to give up. I feel fine. I'm not having any bleeding. Can't you see me next week? So she comes back at 7 weeks. And what do you see? Well, the embryo is growing into the gestational sac. It has a good heartbeat. Things are moving into the uterus. And she says, well, look, things are looking better. Can I come back at 9 weeks? So you have her come back at 9 weeks. And the embryo is growing even further into the uterus. It looks really normal, has a great heartbeat. Should we be relieved? Should we feel that, escape that? Anybody feel okay about this? Well, we can't, right? We need to still be worried because where's the decidua? The decidua is still in the cesarean scar, and the placental vessels are stayed there in this patient as it increased risk for placenta accreta spectrum and the outcomes that I shared with you previously.
So this is a very important audio that we can see with the picture skew depiction. As early as when the blastocyst gets implanted, that is the best time to diagnose, because even when it starts moving into the endogenic variety, we often look at the cardiac activity, the heart rate, the CRL, and then come out. We may tell that, okay, the placenta looks anterior, but we forget to look at where exactly the placenta has got anchored. We should actually start looking at the scar area. Every previous scarred uterus, if she has a pregnancy, always trace the entire gestational sac and see if at all it has got anchored at this area. So that is why if later pregnancies like 11 weeks, 12 weeks, we usually miss this kind of CSPs. So though that is where it makes a very important role for us to do a TVS. TVS is the answer for our early pregnancies. Even if it is 12 weeks or 13, NT scan also, please try to do TVS. I have given TVS and TS. Definitely TVS should score over, because we need to quantify that and also look for the pathology better and try to understand better. Partially full bladder will definitely help, because we also got to know how the serosal layer can get affected with the infiltration. Sagittal and transverse sweeps are very important, not only the sagittal, because placenta is not there in the middle. It can get anchored at one of the corner of the previous scar area at the angles. So that is where the transverse sweep plays a very important role. Always optimize the image and color. Always play with your color. Okay, you may not put color at the cardiac activity, but definitely when you are at the placental zones with the interface of the bladder, always put color. And location. Yes, these are all the things that we low lying, or whether it is on the scar, and the differentiating features between the cervical and all. Early USGs is patients always a very important role. Diagnosis is as early as possible, because you have a definite better outcome. Detailed evaluation of placenta in every time when you try to see right from the early gestation to the pregnancy as till she's pregnant. First trimester diagnosis is definitely possible. Always you should have the high index. Previous LSCS, she is pregnant now, UPT is positive. First thing, think whether am I dealing with the cesarean scar pregnancy, because the incidence is definitely, we are seeing it shooting up. Do not hesitate to take second opinion. This is very important, because if you are not sure, better take a second opinion, so that you have to give a better care to the mother. Multidisciplinary approach will definitely help, because when you are not in a good setup or a low resource setting, you have without making any delay, ask her for a better higher referral. So this is all about, I was trying to take about the imaging perspective of placenta accreta spectrum. I thank all my seniors and my beloved gurus for giving me this opportunity. Thank you, sir.
Thank you very much, sir. That was the chairpersons. Yeah.
Thank you so much, Dr. Raju sir. Very well explained the placenta accreta syndrome. And if we want to save ourselves and save our patients' lives, then we have to assess the sonography assessment of the placenta accreta spectrum very
Yes, sir.
early, and basically, especially in the previous history of surgery, like previous years. Even though nowadays more and more hysteroscopy has been done, so more chances of, even though hysteroscopy also damage the decidua basalis, so we
Yes.
have to aware regarding the previous history of previous surgery like
Any
CS,
intervention in the
yes, or
yes.
IVF consult. Yes, yes. Very well, nicely organized and very well explained, sir. Thank you so much.
Thank you, sir. Thank you, sir. Thank you so much.
Sanjay sir.
Dr. Sanjay, sir, anything you want to say, sir? Dr. Sanjay Brambat, sir.
Pretty good session. I congratulate all of you for organizing such a nice webinar. Thank you.
Thank you, sir. Thank you, Srimati.
Yes, sir. Thank you, chairpersons. Thank you, Dr. Raju, sir, for an
Thank you.
excellent talk on how to diagnose placenta accreta spectrum. I think index of suspicion. Of course, now after diagnosis, what is our next step in terms of management? So that is going to be our next talk. For that, we would invite the chairpersons, Dr. Niket Patel, Dr. Divyesh Patel, and Dr. Piyush Kumar. Dr. Niket Patel is in surgery. He said he will join as soon as we can. Dr. Niket Patel is secretary of the Anand Society. He is a consultant obstetrician and endoscopic surgeon at Akanksha Hospital at Gujarat. He has been awarded the Nirmala Swami Gold Medal for MD OBG by the Governor of Gujarat. He has got a fellowship in minimal access surgery. He has done a diploma from Germany in minimal access surgery and also from Kiel University and also from Oldenburg, Germany, and has got a specialized training in fertility preservation. I am sure he's going to join us soon, Doctor, as soon as the surgery is finished. Next, we have Dr. Divyesh Patel. Sir is the secretary of the Godhra Society. He's a consultant OBG and he's from Shardamangalam Hospital at Godhra, Gujarat. It's indeed a great pleasure to have you with us, sir. And then our next chairperson is Dr. Piyush Kumar Vadalia. He is the president of the Junagadh Society and he was previously the secretary of Junagadh OBG Society. He is MBBS and DGO from MP Shah Medical College at Jamnagar, Gujarat. And he's currently working at Vadalia Hospital and Maternity Home since 1999. I would request the chairpersons to introduce our speaker, Dr. Sarfraz, sir.
Hello.
Hello. Yes, sir. Yes, sir. We can hear you, sir.
Okay. Dr. Kaji is a practicing gynecologist in Himmatnagar. He has done his MBBS, DGO, and MD from BJ Medical College, Ahmedabad. He has taken advanced training in gynec oncology from GCRI, Ahmedabad.
Yes, sir.
Aji, sir.
If you sir, it's okay. Already we are running sort of time. So first of all, thank you very much for the introduction, sir. Thank you.
Okay.
And congratulations, Dr. Durgadas, sir. And it's my proud privilege to on this platform of the first web series of KSOGA Gyanadeepa, and in the presence and with the blessings of all the Foxy leaders like Dr. Alpesh sir, Hiramat sir, Nagaraj sir, Sheila Mane ma'am, Shobha Guri ma'am, and my good friend Kunj Moinuddin. Good evening, everyone. And also I am welcoming all the President Secretary of Gujarat Society. My topic is how to manage placenta accreta by conservative management of S4 technique. Srimati ma'am, you have to share the screen because I am not able to share it.
Yes, sir. 1 second, sir. I will share it.
Yeah.
1 second, sir. I'm just sharing.
It's really a very interesting talk previously on the diagnosis of placenta accreta by Raju Giradi sir. It was very inspiring talk. In detail, he has explained everything. Yes.
Thank you, sir.
Yes. Now you can move. I brings blessings from the Himmatnagar. That is the capital of the Sabarkantha district of the North Gujarat. Next. And I'm going to talk about how to manage placenta accreta conservatively. Next. Particularly, I am going to talk about the S4 technique, which is a 6-stitch technique to save the uterus in cases of placenta accreta. Next. In introduction, already has been told that past disorders are primarily caused by the any surgical intervention on the uterus, and as a history of cesarean delivery is the single most significant factor associated with the placenta previa. As rising incidence of cesarean section are there, incidence of the past is also increasing, which are leading to the severe morbidity and mortality. Next. This is the historical chart showing that the rate and incidence of the past was as low as 30,000 in 1960s, which increasing where we people are entering into our PGs. Most of the us in 2000s it was 1 in 533. So we were not able to see most past patients, but now currently it is estimated that every 272 cases per 1 cases is past. Next. Etiology has been very well explained by the Raju sir, so I am skipping this slide. Next. Clinical complications, as we all know, mainly due to the severe hemorrhage and blood loss, which leads to the mortality up to the level of the 30%. All other complications are also related because of the blood loss. Transfusion-related complications like DIC, lung injury, post-operative, and long-term morbidity are there. Long-term ICU admission, chances of infections increases, physical and psychological trauma to the patient and the family. And apart from that, there is an injury to the adjacent organ like bladder and ureter. If you ask about the neonatal complications, most of the time it is either preterm delivery or emergency delivery, which lead to the NICU admission and respiratory distress syndrome. Next. Risk factors, I will quote this like Putin and Donald Trump. Putin is a placenta previa and cesarean section is a Donald Trump. These two can cause anytime third world war. So past is like a world war. If Putin means placenta previa is there, and if it is associated with one Donald Trump, the chances is 3%. If there are one Putin and two Donald Trump, chances of world war is 11%. If there are three Donald Trumps and one Putin, the chances is 40%. As it is going increasing and increasing, as the rate of the cesarean sections are increasing. But fortunately, in India, we are not getting more than 4 or 5 cesarean sections. So we are quite enough and lucky. Next. If we ask about only Donald Trump, he is the only responsible. Even if there is not a Putin, it can cause war 6.74%. Next. These are another risk factor like China, Pakistan, Afghanistan. You can see myomectomy or uterine curettage as advanced maternal age. As my friend Kunmohini know that IVF practice is doing since long. So any ART procedures also increasing the incidence of the PAS. And in some cases of multiparity, it also increased. Next. PAS grading. PAS grading already has been discussed very well by Raju sir. So I'm skipping this slide also. Shortly, we should know that there are three types of placenta. One is placenta accreta, placenta increta, and placenta percreta. Diagnosis part superbly covered by sir. So skip this slide. So now, before going for the management, we must know that all the management of the PPS is different according to its cause. We are not dealing with the only PPS in cases of the past. PAS is the different case of PPS. We must know that we are going to deal with the only two segment S2 and S3. We have nothing to do with the segment S1 until and unless uterus get atonic. So we have a plan to cut short all the blood supply, denude the placenta, make it die, and then remove so that we can with a little bit less blood loss, we can remove that placenta. Next. I cannot see the slide. Okay. In each and every case of the PAS management, multidisciplinary team is required. It must be a tertiary center with a good radiological diagnostic center with well-experienced senior surgeon like Mahesh Gupta sir, good anesthetic, well-trained in the obstetrical emergency, good intensivist, massive transfusion capacity should be there, and if possible, ICU and ventilator support should be there with cell saver and perfusionist. Next. Before going to our another management of the placenta accreta syndrome, I am going to show one video on this particular case, which was referred to the higher center, which came to me in emergency at 36 weeks with left posterolateral completely covering the placenta previa, coming to the anterior side and becoming the accreta. Next. So what are the other management of the placenta accreta according to the our organization like FIGO, ACOG or RCOG? All these three, like FIGO in 2018 consensus says that planned cesarean hysterectomy is the safest and preferred approach. ACOG practice bulletin 183 also suggested that first line surgical management is planned cesarean hysterectomy. RCOG Green Top Guidelines 27A in 2018 preferred surgical approach is planned hysterectomy, in which there should be no attempt to remove the placenta, just remove the baby, keep the incision above the level of the placental incision, do total or subtotal hysterectomy, often or mostly associated with interiliac ligation, which is best for uncontrollable hemorrhage, but the drawback is loss of fertility. before 2021, after which we have started to do the conservative treatment of the placenta accreta spectrum. In our 10 cases study between 2018 to 2020, we are directly going for interiliac ligation and obstetric hysterectomy in 8 of the cases. Only 2 of the cases where there was a either misdiagnosed or there is a focal accreta, we were able to save the uterus. Next. Another conservative or conventional management which is now not supported by any of the organization, neither FIGO, neither ACOG, neither RCOG, is leaving placenta in situ and hoping for the gradual resorption of the placenta. Use of methotrexate is controversial. Serial beta SCG and imaging follow-up was different, but should be there. Risks are long-term follow-up needed. Chances of delayed hemorrhage or sepsis is there, and another surgical intervention or late hysterectomy because of the torrential hemorrhage can be done or should be done in this type of cases. So this management is right now not supported by any of the organization as a first line treatment. Next. So what next? People are trying different modern conservative approach to save the fertility in a cases of the past. If there is a small focal accreta, you can go for the local resection of the placenta with myometrium. It is if there is a more bunch of the myometrium is involved, you can use the triple P procedure according to the FIGO. But this type of modern conservative approach to save the uterus should be applied only in high selected cases with strong desire of fertility, with experts, surgical team and ICU backup, and must counsel for high morbidity and re-intervention, which is also supported by the ACOG and RCOG guidelines. Next. So in our case, we got this type of report. As I have mentioned in the case summary, there was a posterior low left lateral total placenta previa coming up to the anterior side onto the scar and get accreta. Next. So this is our technique. Just stop the video first. Okay. This is our technique, and the prime 3 important thing in this technique is don't get hurry to deliver the baby. First, do the meticulous bladder dissection fiber by fiber. Go down as low as possible until and unless you are not getting big vessels which are hampering the flow. Now you can start the video. So the first important thing for this method is fiber by fiber, meticulous bladder dissection. Normally we are using monopolar current. Sometimes I have to use the bipolar shearer, which I taught by Dr. Mahesh sir, which is a very handy instrument if there are more bleeding. See, until and unless you are not cutting down the uterus, you are not getting any torrential bleeding. So just relax. Even if you are getting 12-15 minutes to deliver the baby, no problem. Now we dissected the bladder, we put the incision above the level of the placenta, we deliver the baby, we cut down the cord, cut short the cord. There are not that much bleeding. We keep the cord inside. And now we are going to take out the uterus. After taking out the uterus, we have to stop the bladder dissection because there was big vessels there. Now again, we are going down because we have to take our stitches as low as possible. There is not that much bleeding. You can appreciate there. Till now, there is not that much bleeding. Again, we are going down because we have to take another stitches as low as possible. As I show you in the graphic that blood supply of the lower segment come from the S1 and S2. And we are going to try to naked all this area from the blood so that we can remove the placenta. This is our first stitch. We are taking as low as possible on the left side of the isthmus with Vicryl 1 number, taking a little bit chunk of the lateral border of the cervical isthmus and coming out from the broad ligament. This is our first stitch we are taking, which is cutting down all the blood vessels coming down from the descending side to the lower segment. Now there are some adhesions on the upper part of the uterus, which are obstructing to take our another stitch, which is on the upper part of the uterine artery ascending. Same bulk from the uterus coming out from the broad ligament. Still, you can appreciate that still we are not disturbed by the bleeding that much because we haven't tried to separate the placenta. It will be there, some amount of bleeding will be there after we try to separate the placenta, but not that much. See, if this is the right side, same stitch, lower down as low as possible, which is cutting down the lateral descending supply of the lower segment, which is supplying the adherent placenta. So until and unless you are not going to separate the placenta, there will be not that much bleeding. So this up to this time, we have to take all 6 stitches so that the portion we are going to get separating will not be able to bleed that much. This is upper part of the uterine we are tying. The same 4 stitch, and this is main stitch. The 5th stitch we are taking on the midline of the cervical isthmus, the blood supply which is coming from the mid side on the middle of the lower segment, and this is also as low as possible. Why I am emphasizing that you have to do proper dissection of the bladder, because if you will not do proper dissection, you will not able to take this stitch as low as possible. You are not able to cut down the supply. The same stitch we are taking on the posterior as low as possible, transverse stitch. Now I am going to separate the placenta. See, now you will see some amount of bleeding as I try to separate the placenta, because posteriorly it is posteriorly more previa, left lateral it is more attached. But because we cut supply the blood, there is a bleeding, but not that much torrential bleeding. I cannot see the video. Okay. Okay. Now this part is accreta 2 to 4 centimeter, which is completely eaten up by the placenta. There is no myometrium. So I am doing vase resection of that part. I am not trying to separate that part. I have already separated posterior part and little bit lateral part. Now I am taking few stitches in the base of the posterior attached placenta. Still, we are not getting that much bleeding. We are using 3 to 5 minute compression after taking base stitches. This is the anterior part, which is lower segment, which is very thinned out, which will be not helpful for future pregnancy also, and that will hamper our suture techniques. After doing all this thing, you will see the upper segment is, can you stop the video for just a second? Okay. After doing all this thing, after compressing the base of the uterus, once we confirm that there is no that much bleeding or big blood coming out from the posterior base, you will see the upper part of the uterus will become like U shape, and lower part of the incision will become the either flat or C shape. So our duty is to make proper closure of the uterus in favor of the future fertility also. So as you have seen that I have already cut down the lower edge accreta part with the myometrium, and I have seen the upper part was stretched up, so I have also removed that. So right now I have a thick upper part and very thin lower part. Thick upper part is in U shape and thin lower part is in C shape. So what I am doing is I am taking the angle either figure of 8 or as a box stitch in a way that the symmetry of the both the incision side become same. Now you can start the video. Right now I'm taking the stitch on right side, approximating the angle in a fashion. You can start the video, ma'am.
Yeah, so 1 second. Something has happened. I don't know
Okay,
why.
no problem. Okay.
1 second.
Okay, so now I am taking. You can
So
go
I'll-
and fast forward. You can go and fast forward.
So we
Yeah,
have
yeah.
this is okay.
Yeah. So this is because paper is thin lower segment I have, so I have to take 2 or 3 bites from the lower line of the uterine incision and 1 bite from the upper line. So like this, I have to take 2 or 3 stitches to make the proper angle on the one side. Still, I'm not happy, so I'm taking one more bite to approximate properly. So just it is not also important that you remove the placenta with completely devascularized by this technique, the lower segment. It is also important as this patient was having first female child which was expired in NICU. So for her to save the uterus is also important, and to take in consideration the future fertility is also very much important. So like this, I am taking first angle. After completing right side angle, I will go to the left side. Here I have taken more figure of 8 stitch with 2 bites from lower segment and 1 bite from the upper segment. And according to situation, you can modify the things. Here for viewers, I am taking box stitch. You can take box stitch also, where you have to take far away stitch from the lower part and near away stitch from the upper part. So like this, you can take both the angles. After taking angles, again you have to check that, because it was posteriorly also previa. So you have to check the base, that if there any bleeding or not. We found one bleeder, one more small. So we don't want to take any risk. We tied it. Again, we compress, wait for the 3 to 4 minutes. Once we are confirmed that there is no much bleeding, you can appreciate that there, even though it was a past case, but we didn't encounter that much of bleeding. The field is pretty clear. Maybe just because of the camera, you cannot appreciate properly, but the field was very clear. After doing all these things, you can close the uterus. Now you have a proper approximation possible of both the upper and lower uterine incision part. So you can normally take continuous interlocking stitches. Some surgeons are suggesting all figure of stitches, then approximation with 1 or 2 stitches if you are having a little bit bleeding there. So this is the whole process. Next. So there was no bleeding, patient was discharged, there was no bladder injury. These are the FIGO recommendations on conservative management of FAST. Nowhere has been written that you have to do the complete devascularization and separate the placenta. Still, people are searching for another modalities for conservation. Next. So we have the study from 2021 to 2025. I have not included my earlier 2 years case study, where from 10 of the past cases, we have to do obstetric hysterectomy in almost 8 cases. In these 32 cases, we were able to save 26 uterus. We have to do hysterectomies in 6 cases, but there were a reason, like 2 cases of central previa with anterior posterior increta was also there. So I cannot raise reset the posterior wall of the uterus. So we have to go for the hysterectomy in that cases. 2 cases were very severe percrita, and we have to open the bladder also. So we don't want to take any risk on that cases. So we directly go for the hysterectomy in that case. And 2 cases of previous 4 cesarean section with anterior increta. So it is not justifiable to juggle to save the uterus in that case also. Next. So in our results, we found that by this technique, we can conserve the uterus in 81.25% of cases, hysterectomy only 18.75% of cases, and bladder injury 6.25% of cases. Next. So in conclusion, as per conservative uterus sparing technique offers a promising, safe, and fertility preserving surgical option for managing placenta accreta or increta, but when performed with meticulous planning and with multidisciplinary support by choosing the proper case. Next. So my last slide showing that as we evolve with time, so should the surgical treatment we offer in women's health progressing towards safer, more precise, and patient-centered care. Thank you. Thank you very much. Hope I have finished in time.
Thank you, sir. Thank you.
Thank you, Gazi. It was wonderful.
Thank you. Thank you, sir. Thank you.
Suvarna?
Yeah, sir, we request the chairpersons to
Yeah.
give their inputs, sir.
Yeah.
Dr. Divesh Patel, Dr. Niket Patel, and Dr. Piyush, sir. Any inputs, sir? The chairpersons.
It is really a wonderful webinar series, Durgadas sir too, and I was hoping to cooperate with you in any other further webinar series.
Thank you.
And best of
Thank you,
luck for your and Kunji's election
And
for chairperson of infertility and safe motherhood. And
best
I'm
of luck
also
to,
going to take,
yes, best of
yeah,
luck to our beloved Kazi. He is going for medical legal committee, isn't it?
yeah.
Yes.
Thank you, sir. Thank you, sir. Best
Sir,
wishes to you, sir.
Thank you,
sir,
thank you,
So,
ma'am.
thank you,
chairperson's
sir.
comments.
I think Piyush sir is
Is
there.
it?
Yeah.
Yeah, Piyush sir is there.
Piyush sir.
Thank you, Dr. Kaji, for very informative session.
Thank you, sir. Piyush sir.
Welcome. And I will request all societies to support Dr. Kaji for his coming election committee meeting, election, medical legal
Thank you.
committee.
Thank you for support, and also we are seeking support for Durgadas sir and Kunji.
Yeah.
Thank you, sir. So, shall we move to the panel, sir? Bellet, sir. Hello.
Suvarna.
Yes, sir, we are
Yeah.
sir.
Shall we move, sir? Yeah. Thank you, Dr. Swarna.
Yes.
Arun, the series, please.
Already we are lacking in time, so
Yeah.
that is okay. So
Swarna, do you want to introduce moderators or experts in the panelists, Swarna?
Yes, ma'am. Sir, I would like to welcome Dr. M.B. Bellat, sir, MD, FICOG, who's the Dean, KSOG 24-26, and he's the President, KSOGA 2018 to 19, and Professor and former Head of the Department, OBGYN, JN Medical College of Belgavi. Maternal mortality of this, sir, will be...
no. Thank you.
Next
I'll cover up that. Don't worry.
Yes, sir. Yes, sir.
Yeah. Next slides, the experts and the moderators.
Yes, sir. I would like to welcome Dr. Chintan Thakkar, sir, who has done his education from BJ Medical College and Civil Hospital, Ahmedabad. Sir is president of SOGOG and past president Bharuch Obstetrics and Gynecological Society and past president IMA Bharuch. Sir has successfully conducted a gynec laparoscopy workshop in 2018 and successfully conducted SGOG December 2014 state conference. We welcome you, sir.
Thank you.
Yes, sir. And may I now welcome Dr. Usha Mahesh Gupta, madam, who has done MBBS and DGO, and she's consultant at Matis Hospital, Ahmedabad. Ma'am has been practicing obstetrics and gynecology from past 30 years, and she is secretary at Gandhinagar Society. Welcome you, ma'am.
Thank you.
I would like to welcome all the panelists to the session. Dr. Hiril Pandya, ma'am, who is the president of Bharuch Obstetrics and Gynecological Society, Gujarat. She's a practicing obstetrician and gynecologist for more than 20 years at Shevashram Hospital, Bharuch, Gujarat, and she has done her MBBS and MD from Baroda Medical College, Vadodara, and she keeps special interest in high-risk obstetrics and infertility evaluation and treatment. Welcome you, ma'am. Next slide, please. I would like to welcome Dr. Falguni Thakkar, madam, who is secretary, Bharuch Obstetrics and Gynecological Society. Ma'am is director and founder and senior consultant at Mother Care Hospital, Mother Care Nursing Home. We welcome you, ma'am.
Thank you.
I would like to welcome Dr. Snehal Ravi Saheb, madam, who is president of Bharuch Society, and she is director at MBA Hospital and Health Management System, and medical director and consultant at BIMS Multi-Speciality Hospital, Bhavnagar. Welcome you, ma'am. And I would like to welcome Dr. Devraj D. Bhadarkar, sir, who is the founder of First IVF Center in Junagadh, Gir Somnath director. We welcome you, sir. I would like to welcome Dr. Devanand Parmar, sir, who is MD Gynec, passed in 2000 from MP Shah Medical College, Jamnagar. Sir is president of Bhuj OG Society. And sir, enjoying along with the obstetric practice, he also does cycling, kayaking, and trekking. Sir has done many internal iliac artery ligation to control PPH. We welcome you, sir. May I now request Dr. Remy Bellet, sir, to proceed with the further.
Yeah, good evening, and I heartily congratulate for the wonderful webinar organization, Dr. Durgadas, Dr. Alpesh Gandhi. I think he has left, and all others have left, but I take their blessings, and Dr. MG, Dr. Nagaraj, and others, and Dr. Durgadas, I congratulate, and also in advance, I'll see that you will be the chairperson of the Safe Madhur Committee, and Kunjimudi and Dr. Sarfraz. So with that, can you allow me to share my slides, please?
Yes, sir, you can share.
So, you know that most of this you have seen, I bring greetings from my institution, and these all have been introduced. So my job was because I was given more than 45 minutes time, but now I will cut down all this. So we are more interested in why we are dealing with this. So what are the symptoms? I skip all this. I will concentrate on this. We are losing 712 women during pregnancy and childbirth every day. Almost, you can say that one death every 2 minutes, and 260,000 worldwide, and 30,000 we are now. Fortunately, we are less than the CS cervix deaths. So almost 82 to 85 deaths per day. Once when we had joined, it was very high. We used to lose around 556 maternal mortality was there. So today we have reached to 88, and we should be able to reach before 2030 the SDG goal of 70. For that, we need to address this important global problem, which is highly prevalent. And you should see that this is the most common cause for the anemia prevalence. And even WHO, amongst the maternal mortality, that 64% of them had the hemoglobin less than 8, and 21% had less than 5 grams. So you can understand, Dr. Devanand, can you explain what has happened in NFHS 5 compared to NFHS 4?
Sir, the rate of anemia in children and women are increased from NHS 4 to NHS 5. More children
Yes,
and
very
more
good.
women are become anemic when then 4 to after any National Health Family Survey 5.
Correct. Very nice. And also anemic women rose from 57% from 53. And most importantly, teenage girls, it has been increased from 54 to 59. That means even anemic men have become more anemic now. So that is the tragedy in spite of all the measures.
Any reason for that? For increasing that?
See, for most important reason is the quality of food what we are eating.
Yes. I was thinking that.
And also the iron rich food are not been eaten well, and especially there are some things you can see here. The pregnancy anemia has gone up.
Yes.
And in spite of this, see, it's humanly not possible. And even in that literature, it is NFHS told that 100 days iron taken by the woman have come down because compliance is very, very poor.
Yes.
See, when you see the Gujarat, it's a well-developed, very rich state. Look at the anemia. Karnataka, look at 45. Rajasthan, 46. See, almost all the states have higher incidence of anemia. This is in spite of 1960s recommendation of oral iron therapy. So you see this. So Dr. Hiral, can you tell me what are the important maternal effects of this on pregnancy outcomes due to anemia?
Yes. Good evening, everyone, and thank you for giving me this opportunity. Now, the important maternal effects because of anemia are preterm labor, IUGR in fetus, postpartum hemorrhage, sepsis, and congestive cardiac failure in mother.
So important one. And these are the other pregnancy outcomes, madam. Like you said already, FGR, preterm births
Yes.
is more common 2 times
Abruptio.
and low birth
Abruptio
weight.
placenta.
Yes. So
And
these are the, yes.
and if she is going any surgical intervention, then chances of wound infection, sepsis post-delivery, sub-involution
Correct.
post-delivery.
And on the fetal and neonatal, you can look at this. SGA, LBW, fetal brain development, iron deficiency in first few months of life also increases the risk of the incidence of cardiac disease and diabetes in the later life of that baby who's born to the mother. So you can imagine why our earlier the longevity was less, because we are faced with all these complications much earlier than the developed world. Dr. Snehal, can you tell me because there are 4 or 5 mechanisms by which PPH is caused due to anemia. I one by one go to one of the panelists. Snehal, can you tell me how anemia causes PPH? Is Snehal is there? Ravi Sahib? If she is not there, what it does is it increases the heart rate and cardiac output, and
No,
it
she's there.
increases.
She's there. She's there. I think she has muted, I think. Madam, Snehal, madam. I think some problem with her.
We can come back to that answer later. Can you, Dr. Devraj, tell how anemia causes PPH?
Sir, I think
Dr. Devraj?
Sir, I think sir is stuck with some work. He's not there, I guess, sir.
Okay. So see, please understand that anemia increases the blood flow from bleeding vessels because there is a reduced viscosity. Because blood viscosity mainly depends on the red cells, and blood viscosity falls with decreasing hematocrit. And as blood viscosity falls in anemia, and there is physiological dilution also. So that's why blood flow is faster and the bleeding is faster. Dr. Falguni, can you tell us another mechanism of how it causes?
Yes, sir. Now, anemic blood clots, they are more susceptible to fibrinolysis. The RBCs usually gives resistance for the fibrinolysis of the fibrin clot. Now, if it's anemic, RBCs are less, so the fibrinolysis increases, and hence the chances of PPH increases.
Very good, madam. So, and also, what is laminar flow, madam? So, see, anemia prevents the platelet margination, increases the bleeding time, because in normal blood flowing vessel, when it is not anemic, the RBCs are flowing in the center and the platelets are at the periphery. And this is called as laminar flow. And this, whenever the vessel is ruptured, the platelets at the wall form the plug clot, and that prevents. But this laminar flow is disrupted in anemia. So that's an important reason. Dr. Devanand,
yes, sir.
can you tell me another reason why PPH occurs?
Generally, due to anemia, there is the loss of oxygen supply of the uterus. It's decreased. So oxygen requires the contractility of the uterus. So because of the less oxygen, the uterus you get easily fatigued out, and it remains atonic in some cases. So that causes the PPH.
Very nice. So you know that, see, anemia is oxygenation of any tissues is less, and that
Sir,
is further. Yes, sir.
Sir, I remember one case of PPH during my post-graduation in 97-98 MPSA Medical College. There was we were arranging for blood, but meanwhile our sir come and he says that improve the oxygenation by giving the oxygen to the mother, so it will help in the contractility. Meanwhile, the blood comes. So that's I also remember from studying in our MPSA Medical College, Jamnagar.
Yeah, that's another thing, but she should have some amount of RBCs to carry that inhaled oxygen from the lung to the tissue.
Yes.
So that is where we need to have good hemoglobin. And please understand, every myometrial cell which to contract or function, there is an enzyme which needs again iron. So that's why iron deficiency further causes muscle weakness and fatigue. It prevents myometrial contractility. Very nice. Dr. Snehal, can you tell us what is the impact of iron deficiency and what is the roles of iron and explain this vicious cycle one by one?
Yes, sir. Iron deficiency affects
The role of iron.
Yes, sir. The iron deficiency will affect all of the functioning of every cell. As we know, every cell and organ in the body, physiology and functioning, iron is very, very important. It is important for oxygen transport, for erythropoiesis, for energy production, DNA synthesis, and cell proliferation and growth. So, without iron, everything is going to be affected. And we know that the vicious cycle is that once an anemic female gives birth to a child, that fetus has less iron stores, and so the baby is going to have less iron stores, and that baby is going to be anemic. So from the infancy onwards, that iron deficiency state, unless corrected, it goes to adolescence. Again, the adolescent, especially girls, because of menstruation and other problems, she may again be anemic. And then in adulthood also, when that female gets pregnant, so again she would be anemic, and she would give birth to an anemic child. So that becomes a vicious cycle. So unless we correct it somewhere, especially we can correct it in our case as a gynecologist, we can correct this when the female comes to us for preconception counseling, or sometimes whenever
Yes.
it comes to us directly with pregnancy. So as soon as possible, in the first visit itself,
Yes.
we get her hemoglobin and other reports done, and so we can come to know if there is less hemoglobin, then we have to get to the point where whether it is an iron deficiency or a vitamin B12 deficiency,
Jayashree,
and try to
mute.
correct. So two ways to
Knees
correct
good activity.
prior to pregnancy or early in pregnancy.
Yes. So that is why all of you agree or no, panelists and my audience, that we should break this vicious cycle. Yes.
Yes.
Because we want to ensure that the infant is not born with iron deficiency of iron stores, not iron deficiency anemia. Please understand, iron deficiency anemia is severe spectrum in this. Dr. Falguni, can you please define and explain degrees of anemia and explain the dilutional effects of pregnancy, and what is the additional requirement of iron in pregnancy?
Yes, sir. So now anemia is defined as a decrease in the oxygen carrying capacity of the blood due to decrease in hemoglobin concentration of the red cell mass. Now, according to WHO, the cutoff level is that if the hemoglobin is less than 11 gram per deciliter or the hematocrit is less than 33%, then we label her as anemic. And according to the CDC criteria, hemoglobin less than 11 gram per deciliter in T1 and T3 and less than 10.5 in the second trimester is considered to be anemia. Now, anemia can be classified into mild, moderate, and severe. So, if the hemoglobin is less than 4, it is severe. If it's between 4 and 7, if it is less than 4, it's very severe. If it's between 4 and 7, it is severe. Between 7 to 10 is moderate, and 10 to 11 is mild anemia, according to the ICMR classifications. WHO criteria, the things are same. Only thing is that the very severe classification is not there in it.
All it is just in one under severe. And
Yeah.
this is the physiological anemia because of what happens exactly.
Yes. So there is hemodilution during pregnancy. The reason for hemodilution is that the blood volume and the plasma volume increases approximately by 40%. In contrast to that, the red cell mass increases only by 18%. So that causes dilution, hemodilution during pregnancy. And the maternal need for iron during pregnancy is approximately 1000 milligram.
Very nice, madam. Thank you for those. Dr. Devraj, do you think diagnosis is challenge? How can we diagnose? And what is iron deficiency? And what is iron deficiency anemia? I think Dr. Devraj is there.
He's not there, I think so.
So the challenge is where we should know. what is the iron deficiency and what is iron deficiency anemia. Iron deficiency anemia is, already we have lost the storage, and even in the hemoglobin, it has gone down. So that means that this woman is in the severe spectrum of this iron deficiency anemia. So the single best parameter is ferritin. But in Indian context, the ferritin may not be the appropriate one, because our women are with multiple infections, especially urinary tract infection. Whenever there is an infection, ferritin is increased. You must have seen that during COVID times, one of the prognosticator was ferritin level. So it has its own limitation, acute phase of infections and chronic infections. You must have asked why in chronic kidney diseases, this is a challenge. And serum iron, that is the best is TSAT, and there is now soluble, another STFR, the factor which is very, very important. That is transferrin receptor, soluble transferrin receptor, but it is now they have started using in clinical practice. So we need to rule out these all. That's why it is a challenge. Hemoglobinopathies in our own population, which is not an endemic area, but still we got, because now people are moving around all over and settling somewhere. We had 9% of hemoglobinopathies amongst the anemia. So please don't think that we do not have any hemoglobinopathy. I routinely evaluate in the first visit itself by electrophoresis hemoglobinopathies. So you please understand, iron deficiency without anemia, it's a new concept. HB can be normal, but the woman may have the iron store deficiency. Please understand, if the woman does not have the iron stores, she will be less likely to transfer this to the baby. And that is very, very important, because breast milk is very less with iron. So this woman, this baby, which is born with less iron stores, is more likely to become further anemic in the exclusive breastfeeding time and even first 2 years of life. So that is why we need to treat not just anemia. Anemia is a severe spectrum. We should evaluate whether she is store deficient. That is by TSAT. So you can understand with this, what is storage iron, what is transport iron, what happens, first source gets depleted, and even transport iron and functional iron, and you can see their severe anemic, and you can look at what these happen. So ferritin level relatively less than 30 and microgram per liter, or transferrin saturation when it is less than 20, we should see that this woman is iron deficient. So this is what happens. So please understand, the iron ferritin is not only the one marker, but in addition to, because if you want to use the ferritin as one marker, there you need to look for either HSCRP or procalcitonin or other inflammatory markers. In the absence of that, ferritin is wonderful biomarker to test iron levels. Dr. Hiral, what are the principles of management of anemia?
Now, when we think of any management, we need to first identify the cause and treat the cause. And second is dietary supplements, and third is supplementation of iron itself. Now, if we are advising about dietary supplements, then we should advise them about both animal and non-animal supplements, which includes meat, fish, poultry and cattle meat. And in non-animal, we can ask her to go for legumes, green leafy vegetables, etc. And then if we go for iron supplementation, we can ask her for oral as well as injectable, depending on the compliance and severity of anemia.
Thank you. Dr. Snehal, what are the modalities of treatment for iron deficiency anemia?
Sir, usually the first line of treatment would be oral iron. The oral iron, many preparations are available in the market. As long as the patient is tolerating and the hemoglobin rise is being shown, we should go for oral preparations first. If a patient is not responding to oral medications or not tolerating, then we can go for parenteral iron, for which many products are available. And last would be blood transfusion. These days we usually do not go for blood transfusion unless it's an acute severe blood loss. Otherwise, oral and parenteral is the route to go. First oral, only if it doesn't work, then we go for parenteral.
I just have one personal question, if you don't mind. Did you take 100 days iron orally during your pregnancy?
Yes, sir.
I doubt my own because many of the obstetricians themselves do not take. So, Dr. Devang, what are the challenges of oral iron?
Because none of them seem to be working. And some of the other side effects.
See, that's why that you should be practical on this. Please tell that complaint. That's why Dr. Devang,
Yes, sir.
Devanand, sorry, Devanand.
Yes, sir. Sir, usually I am fighting with the patient for their compliance regarding the oral iron therapy. My most of the patients are come from the low community or rural areas. So they generally they said they are taking the treatment from government Anganwadi worker, and they then reject my tablets of iron therapy. And later we come to know that they were not taking from there also. And other
Yes, the reason, tell us why, what are the challenges?
yes,
One
yes,
is,
their compliance, their GI
yes,
side effects, and intolerance, they are the most common things too. And sometimes in poor patient, there is also health, economic problem also. If we are trying to write this good and higher iron dose therapy, so they can't afford also. That
so,
is also one factor in this, and there is just come to know from that there is a role of hepcidin also, that even we are trying to increase the iron, but because of this high hepcidin level, the iron will not get absorbed.
so I just want to highlight here, as Nehal Madam has said, it's very easy to advise others. And when it comes to our own, we don't take 3 days continuous antibiotics. And
Yes.
woman advising 100 days of oral iron every day, and that too, which is not going to work. Please understand, every day oral iron, everyone we have since 1964 we are giving. You think it has worked? What has happened in NFHS 5? Anemia has gone up. See, the method of administration, even if you are giving oral iron, every day if you give iron, it doesn't because of this hepcidin. So why parental iron? Now you can tell Dr. Whoever, Hiral.
Yes, sir.
Oh, can you answer why parental iron? Look at this,
Sir,
please.
sir, I differ in the opinion for parental iron, but yes, parental iron at least we
Yeah, please
is
let
given
me
in
listen to that. You first tell. I would like to listen to you.
regarding what, sir?
You said you defer to from parental iron. I want to know
Yes,
the
sir,
reason.
because I am practicing since 21 years, and I work in a small town, Bharuch, but I have never seen that patient not obeying or not complying about oral iron therapy if they are counseled properly.
No, you must see, madam. I am talking in general eligibility. Gujarat has 67% anemia rate, and this is
Yes, sir,
from
I
NFHS data.
don't disagree to it,
No,
but it should be a tailor made approach, because you can find many patients, those who understand and those who are ready to take oral iron.
how are
But
you
yes,
prescribing,
parental,
madam? How are you prescribing?
like,
I'm
sir,
very critical. Oral iron, how are you advising to your patients?
sir, like it should not be taken with meals. You should
No,
take at
every day
this
are you
time.
giving her, asking her to take every day?
Yes, sir.
So read about this. Kindly read. What is hepcidin? What does it do? See, every day when we give iron, there is an increase in the hepcidin. Next day, what you give iron, it doesn't get absorbed because hepcidin controls the iron metabolism and absorption of iron. That is why we are unable to, in spite of having since 6 to 7 decades of oral iron therapy, we are unable to control this.
But
And
sir,
main mechanism.
a human
Yes.
nature, it is always there that if I prescribe.
No, even that is why I'm telling, if at all you want to give oral iron, I agree that it is oral iron can be given. It is not everyday level. It should be given either alternate day or twice a week, because this is what the reason is. And all these infections increase where hepcidin can go high because of all these. If there is a high iron, if there is an infection, and the endothelial reticular system is stressed, all this will increase the hepcidin and that prevents. So that's why if our women are having chronic infection, if they are having you are giving every day, it doesn't get absorbed because the hepcidin comes into the picture. That is why 1000 milligrams of iron that is required, just now we had mentioned, cannot be covered up in 180 days of oral iron. If you give every day, it doesn't get absorbed. And alternate day you give, it cannot take because 10% of the oral iron only gets absorbed. So we should have this in concept. And with that background, I am asking on this. So this is what happens with the hepcidin and oral therapy. So we should be able to go for this. So Dr. Devanand, why parental iron now?
So one of the thing is its compliance, and other thing is when there is moderate anemia, and we are or severe anemia, and we are approaching the term size 38, 37 weeks pregnancy. So we didn't have time to correct with oral iron therapy. So it is necessary to switch on to the parenteral iron therapy.
So you understand that oral iron cannot meet the requirement, and daily dose will not get absorbed due to hepcidin, and early parenteral iron can associated earlier ones. That is Imferon when it came, iron dextron, they were all dangerous. But second generations were safe, but we need to give more frequently like iron sucrose. And now currently third generation, they are safer and with very, very low adverse side effects. And what are the can you explain on what are the formulations which are available?
There is
single dose.
Single dose is most commonly used is ferric carboxy maltose. 20 milligram per kg we can give it to it. And another is iron iso multidose. And
these two are available in India. It is now it is called iron isomaltoside as ferric derisomaltose. But safe, we did our own rapid iron study. And I wish to all of you to read that American Journal of Obstetrics and Gynecology. It is published in March this year, that is 2025. And these are the other IV iron preparations available in Western world, not with us. And this ferric carboxy maltose can be given. Any drug which can be given in IV when we give antibiotics, or even when we give the vitamin B12 and folic acid, they are known to cause 1 in 1000 to 10,000 some amount of reactions. We should be careful to give. Dr. Hiral, why all parental irons are covered by carbohydrate? You see the carboxy maltose, iron isomaltoside, iron dextran, like this. What are the different preparations?
Every iron, IV iron agents are covered with carbohydrates because it helps to release the elemental iron slowly and steadily. And the inner core, there is salt of iron.
So iron core is unstable. It is being stabilized by the carbohydrate moiety. That is why every parental iron is having the carbohydrate moiety. You saw that iron sucrose, iron dextran. Now low molecular iron dextran also is there, and iron fermoxytol also is there. So these are some of the preparations. I'll rush through these. Ferric carboxy maltose, isomaltoside, fermoxytol dosage, and low molecular dextran. These are all available. Dr. Falguni, what are the contraindications and prerequisites to ensure safe administration? Hello? Hello?
Please muted. Madam, unmute yourself.
Yeah. Okay, sorry. Okay, so the most important contraindication is known hypersensitivity to any iron compositions. Any iron deficiency anemia which is not caused, any anemia which is not caused by iron deficiency, you don't need to give iron, parenteral iron. If there is a known case of iron overload or disturbance in the utilization of iron, less than 3 months of pregnancy, you cannot give it. Acute and chronic infections, autoimmune disease, and drug-specific contraindications are there. Now, the most important prerequisite is that we have learned as the first thing that there can be a hypersensitivity reaction to it. So whenever we are giving it, a trained staff only should give it, and resuscitation facilities should be available. So as a rule, I
Well,
tell my staff that whenever they are going to start it, they have to keep Evil and Exona nearby, and they have to check the resuscitative measures, and only then they have to administer it, so that they don't have to run about in case they have a reaction to it.
yeah, one important message, madam, is these are usually not mast cell mediated. Best drug for any these are reactions is methylprednisolone, or you should use is hydrocortisone. Additionally, you can keep the H2 antagonists as well as Avil for most of the other situations. So these drugs must be kept ready, and adrenaline must be there. Very rarely one can encounter. Out of the 3,000 infusions in our study, we had only one mild anaphylaxis, but that was managed by outpatient. So, but we need to keep all these emergency drugs. These are the other side effects which are known to occur, common, less common, and rare. So, anaphylaxis is very, very rare. Some amount of body malaise can be there. Dr. Snehal, effects of fetal and infant brain effects of iron deficiency. Can you elaborate?
So, three types of pediatric populations are at very high risk for iron deficiency. As we discussed first, the fetus and the newborn, those who are coming with deficient iron stores and having, again, also having iron deficiency, anemia. The children, those who are from 6 months to 2.5 years, and also teenage girls. These are high risk populations. And all of these three will show a wide range of motor and cognitive deficits whenever they are iron deficient. And unlike adult iron deficiency, early iron deficiency can result in neuro or developmental alterations that persist despite iron depletion. So these would be long lasting effects. So need correction as early as possible.
No, we should be correcting it. We should prevent these. That is important. So that is why mother should have very good storage.
Yes, but if it has not been done, try to detect it as early as possible. First is the mother has to be proper repletion of iron stores, so that she will pass on those good iron stores to the baby.
Dr. Devraj, Dr. Devanand, neuro consequences of iron underloading. That's what I told. If it is more than 80 picogram per ml in the cord blood, that is the adequate transfer of iron to the mother. I mean, from the mother to the baby. If it is not there, what are the effects, Dr. Devraj or Dr. Devanand?
There is a because of a low hemoglobin in the baby, there is abnormal neonatal brain function, poor recognition memory, slow speed of neural processing, poor bonding and maternal interaction because of the iron. And in long term, it will cause risk of autism, risk of schizophrenia and neurocognitive disorders.
And postnatal iron deficiency, the lower stores in the newborn are depleted earlier. Earlier onset of postnatal iron deficiency anemia. Postnatal iron deficiency causes acute and long-term neurobehavioral abnormalities. That is motor dysfunction. Social effectiveness is also affected. Risk of depression, anxiety in adulthood is more common. So just in summary, I can tell you, if there is iron sufficiency, this is the brain networking which develops so nicely. And if there is iron deficiency, this is how our brain networking happens. You can decide whether you want our pregnant woman to give adequate iron and prevent anemia oxygenation to their babies, so that they are well nourished and the brain development. Not only that, apart from that, other system development is also important, because nowadays we are finding the diabetes also more common. What happens is, even 1000 milligram what we give as an IV iron may not be sufficient in diabetic mothers, because baby will be polycythemic. Here, what happens is, there is a preferential use of iron. Instead of going to the brain development, it will go for the polycythemia RBC formation. So we need to appropriately control the diabetes of a woman if you want to see that even her baby is not affected by this selective iron transfer. So it's very important. Our woman should have adequate stores to see that the baby is developed, their brain well and other systems well developed. So one message from each of you.
Sir, I would
Panelists.
I would like to say that the new thing which we, rather one thing which was consolidated from this meeting was that we will try to not give oral iron daily. And
Thank you. Thank you.
and early resort to parenteral iron, because in the end, making good iron stores in the pregnant female is very, very important to break the vicious cycle. As good as getting preconception counseling or adolescent girls we are treating for anemia, so it is as good as that. So all of this is important.
Next person.
Thank you
For
for
anemia. For
Hello?
anemia, I would like to say that we are going through an endemic and epidemic of anemia. So
Fantastic.
it's an
Go ahead.
ongoing epidemic and endemic. So the treatment should be started right from the pubertal girls, stretched up to the geriatric age group.
And being an obstetrician, when the infertility patient comes to you or a relative of you is getting married, tell them, evaluate their iron and their, anemia and hypothyroidism and diabetes before they become pregnant. This is one message. Okay, next, please. Next person.
Yes, sir. And more focus on if we are giving iron therapy, oral iron, parenteral iron, if still patient remains anemic, we will try to focus on the cause of the deficiency of iron, anemia.
Yeah, you need to evaluate properly. That's there always.
Yes.
Yes. Next.
Yes,
Proper
sir.
evaluation.
Yes, sir. So the three main take-home messages which we get from this is: number one, no daily iron, make it alternate day. Resort to parenteral iron as early as possible. And number three, search for hemoglobinopathies also, because that may also be the cause for the anemia.
Fantastic. Next person. Last.
That's all, I think, sir.
Yeah. Thank you. And see that it is how to the infusion. I had a video, but because of the time, I may not be able to show you. And just one important conclusion before Dr. Durgadas says his comments and others, that treat anemia before she becomes pregnant. See, this is, I request you to go through my one general article in Hindu on May 27th of last year, that manage anemia before she becomes pregnant. Prevent anemia for prevention of anemia related complications. And if we want our next generation to be smarter and intelligent, their mothers not only should not be anemic, but they should not be also iron deficient. So prevent anemia at every level. Let us make anemia free India and achieve SDG goals well before 2030. Treat iron deficiency before she becomes anemic. So thank you, Dr. Durgadas, Srimati, and others for giving us this opportunity. We want to ensure that every wanted pregnancy must end in a healthy mother and smart and intelligent baby. Thank you, Dr. Durgadas, all the panelists, wonderful panelists. I am really thankful to all of you for your great contribution, and hope that you will all support to my friend, Dr. Durgadas, and he will be the chairperson of the Safe Motherhood Committee. Thank you. Thank you so much.
Thank you,
Sir, any
Dr.
comments
Bellal.
from
This was a
sir?
video. I don't know everywhere. This video is very important. I just want to share this. Communication counseling is very, very important, because if you don't counsel, here the husband is there during the delivery, and the neonatologist or the obstetrician did not tell that this is one of the way of stimulating the baby, and what happens, you just see there. So we should be careful in our communication and counseling. Thank you so much. Dr. Durgadas, please.
Thank you, Bellal. Excellent, excellent message. And all the Yes. Sir, good evening, sir. Good evening, sir.
Just let me have an opportunity to wish all the best to Dr. Durga Das. So that's why just I have entered in this webinar.
So nice of you. That's called affection. Thank you, sir.
And all
Thank
the
you.
experts also I must thank here.
Wonderful panelists. Wonderful. And lots of good message. Sir, Mahesh sir, you will be
Yes,
there
sir.
in the next. You are subsequently you are into our fold, sir.
Yes,
Bellad was
my
asking.
pleasure.
Yes.
My pleasure. And my our fellow Gujarat Society President and Secretary, all I am requesting them to do active voting in favor of you. Because on the screen I see many.
Dr. Chintan Thankar and Dr. Usha Gupta. Thank you very much. You want to add any points? Please, you are
Thank you,
welcome
sir.
to do that.
Thank you, sir. I think I should let Mahesh Gupta sir to finish. I think he was in middle of something. He was little bit talking. I just wanted to add two or three points to what Dr. Bellad sir said. Uh, it was really wonderful. I mean, a lot of new things for us also in this subject. A very old and very conventional subject. Sir, I just wanted to add two things. I like that concept very good. That there could be an iron deficiency without anemia. So that's the patient having normal hemoglobin level can also be iron deficient, and that's being very well understood by the fact that sometimes if during delivery or cesarean a woman bleeds less, but the hemoglobin falls a lot. Probably this should be because of the fact that they have very low iron stores. So that way, parenteral iron probably is very useful for replenishing this iron stores also. And the second thing, which was a very eye-opening or very striking to me, was iron tablet not taking iron tablet daily. Now, sir, I just wonder whether this concept, I mean, because the government programs, they also recommend the iron tablets to be taken daily, whatever the community, this ASHA workers and this all Anganwadi workers. So now, I mean, has this concept been accepted by the government programs that, you should take oral iron tablet alternate day? And sometimes we have found striking results with, I mean, we all are mostly are giving oral tablet daily. And we have seen, we have evidenced a striking effect of hemoglobin rising to more than 2 or 3 grams in 2 months or so. So I was just a little, in dilemma whether this has also been accepted by the government programs.
Government has still not taken. I have sent to all the directors and heads of the government of India as well as state government. But I have sent the articles also. Even if you, Chintan, I have your number. I can share that alternate iron or alternate day iron or weekly twice iron is better than everyday iron, which there are some studies. And oral iron amongst the available now, all along we were believing that ferrous ascorbate is the best, but it is not so. The best oral iron preparation is sucrosomial iron or the the another that is liposomal iron preparation, which can be given alternate day or weekly twice iron. You can give higher dose, but you can give
It has to be
alternate
given
day
on alternate day.
at least.
What about the heme iron, which have been introduced? I mean, which are
But heme iron, what happens is there is a breakage of this in the stomach. So they have not compared between the liposomal versus heme iron, because heme iron is a non-veg source of iron. Many of the our Indian Hindus, it may not be acceptable. They declare their red mark is there if you look at the heme iron. And especially Gujaratis, Rajasthanis, they are high vegetarian population. We also should correct vitamin B12 in anemia, because that is one thing. And secondly, vitamin D deficiency is also high, sir. So these all need to be corrected if you want to really prevent anemia in pregnancy.
And co-prescription of vitamin C too, because that would increase the
Yes,
absorption.
that will improve the absorption of iron. But that's what I'm telling. I stopped giving oral iron to my pregnant women, sir. I give before the pregnancy itself, like infertility patient or those who are planning pregnancy. And once they conceive, 3 months later, I give one dose. And if they are really anemic, I give second dose at 28 weeks because that is the one which get transferred to the baby.
Right, sir. Thank you.
Usha ma'am, may I request you to share a few words, ma'am?
I'm Mahesh Gupta, not.
Sir,
Yes, sir.
Swarna,
Yes, sir.
he is Dr. Mahesh Gupta,
Yes, sir. Yes, yes.
pioneer work in PPH and wonderful. And there is the PPH Mahesh Gupta sir's stitch is there.
Okay.
To that extent, he owns that authority.
So he is a teacher
And
of many of our colleagues, including me, regarding PPH.
Yes. And just now, Usha Gupta was there. It's his wife.
Yeah, just I entered in the last moment and
Yeah.
I heard Dr. Billard
And
speaking.
actually, sir, I wanted to include sir. Then what I thought is I will include in Maharashtra this thing. So it has been already included, sir. It's my pleasure that you. That's what I told you. Will be in our folds. I want that Mahesh Gupta surgery should be propagated throughout India, wherever I go. At least
So
in one state, one webinar will be sir's video. That's what I have decided.
What this Dr. Kaji showed, all the steps, it was imbibed by me in my workshops and my conference, and he used to phone me before doing surgery, and then he generally did the surgery. Now regarding anemia, this everybody now knows that anemia Mukt Bharat and anemia correction in antenatal period is very well accepted by the patient also, by the doctors also. But I'm little more radical as far as the iron supplementation is concerned. So in my all patients of previous 2 or 3 cesarean section, all patients of Rh negative woman, all patients of a placenta agreta spectrum, all patients of multiple gestation. So all these patients are irrespective of their iron status, means serum ferritin status or hemoglobin status. Generally, I used to give them ferric carboxy maltose because I am more concerned about the postpartum period. So in
Correct.
postpartum
Absolutely
period,
right.
so postpartum period, whatever there is a blood loss, that will be compensated in the postpartum period by giving this long-acting iron. So the immunity level, so the resistance level, and so the recovery level of these cases, because all these cases needs a cesarean section. So the postoperative periods are very good if you give this this carboxy maltose in antenatal period. So I am little more radical about supplementation of the iron.
Sir, we have a protocol for all these high-risk patients, especially placenta percreta. I ensure that they are doubly stored sufficient and ensure I also give progesterone for these patients because if there is a non-adherent part of the placenta, it is placenta previa, they may bleed, you may have to intervene early because we want our woman to be at least 36 weeks in India to do that, the placenta percreta. So we have a protocol based of management of placenta percreta, sir. Only thing is we are not incorporating your stitches there. After internal ILAC, I ligate the uterines through the stangens clamp, which I saw first time when you used there.
Satinsky clamp.
Satinsky.
So we all the time we are speaking about the antenatal management, but as far as the anemia correction is concerned, the postnatal management is equal important.
Yeah, every delivered woman, every hysterectomy patient, every D&C infertility evaluation, I send them after that 1 gram IV iron and go because they might become pregnant or next pregnancy they should not be anemic. So this is the protocol we are following in our institutions.
That's very good, sir.
Thank you, Durgadas, for giving this great opportunity.
Thank you.
And Dr. Srimati, I hope I met your expectation, but because of the time factor, I could not cover entirely. Some of these slides I had to, fast forward them. Thank you.
Thank you, Bellas, for the wonderful panel, and all the panelists were wonderful. Sir Mahesh Gupta, sir, your presence had made my day today. Chintan, sir, thank you, sir, for joining and joining the discussion.
Usha
Over
Gupta
to Srimati.
is also there.
Yeah.
She has some work, so that's why she had gone.
Thank you, sir. Thank you. Thank you.
Okay.
Swarna, you want to give a
Srimati?
concluding
Yes,
remarks?
yes. The session is now open for the questions. Any questions from the audience, please?
Vote of thanks. Vote of thanks.
I think there has been a good, everybody has said it's been a very informative panel and very informative session. So I think we thank Durgadas sir for having thought about this webinar series and starting it. Of course, we wish him all the best for a safe motherhood committee chairperson, election. I'm sure he would come out as a chairperson. So with all the blessings of all the seniors, we are very junior, but we can only pray. Then with all the blessings of the seniors, I hope you're able to ascend to that throne. So with that, I would like to thank the chief patrons, MG sir and Nagraj sir, for being with us all the time. Our chief guest, Dr. Alpesh sir, again MG sir, Sheila Mane madam, and Kunji Mohidin sir, and of course our secretary and the honorary treasurer, my coordinator, Dr. Swarna, and of course all the societies of Gujarat who have participated, the two speakers, Dr. Rajagiradi and Dr. Sarfraz sir, and especially special thanks to Dr. Sarfraz sir because he has been the one who has been behind all the Gujarat societies and sort of got all of us together. So thank you very much. I thank all the chairpersons and I thank the experts, Dr. Chintan sir, Dr. Mahesh Gupta sir. We are really honored to have you, sir, and all the panelists. And special thanks to Bellet sir for having done a wonderful panel discussion. So please watch every Wednesday. We are going to be coming with interesting talks, interesting panel discussions, and we are hoping to cover the whole of the width and breadth of India and all the Foxy societies. So we are going to be coming back again with yet another webinar next Wednesday. So looking forward to active participation from all the members. And with that, I would bring this to a close, sir. Thank you very much.